Hello and welcome to this presentation on primary care networks in the English NHS, collaborative networks and the COVID-19 pandemic response. I'm Dr. Jonathan Hammond from the University of Manchester. My co-authors from the University of Manchester are Professor Kath Checkland, Dr. Lindsay Warwick-Giles, Dr. Donna Bramwell, and from the University of Kent, Dr. Simon Bailey. This presentation is based on early findings from one of the studies comprising the National Institute of Health and Care Research's Policy Research Unit in Health and Social Care Systems and Commissioning, and reflects the views of the authors rather than any governmental department or arm's-length body. As we are all acutely aware, the COVID-19 pandemic has had significant implications for the organisation and delivery of healthcare across the world. The arrival of the pandemic coincided with our National Study of Primary Care Networks, or PCNs, in the English NHS, and the response of PCNs to the pandemic became a focal point of our work. We sought to capture some of the experiences of those on the ground, reorganising at speed to provide remote triage, create hot and cold locations to separate COVID-positive patients from those without, and then later implement the vaccination programme alongside existing work in general practice. This provided a window into the efforts, challenges, successes, and emotional response of individuals and groups working through PCNs, but also provided a case study of the implications of a macro-exogenous shock on the implementation of national policy involving interorganisational, goal-orientated, collaborative networks in healthcare. The aim of this presentation is to provide a brief account on both of these fronts, so to look at the texture of the experience of those involved, but also to offer some insights into the policy itself and the implications for the policy. So first I'll provide some details about PCNs themselves and their nature as collaborative networks, before a brief overview of methods, and then offer an account and exploration of PCN experiences of the pandemic response, particularly the initial response and subsequently the vaccine programme. PCNs are a policy initiative developed by NHS England and formed in 2019. They're groups of geographically proximal GP practices averaging about 50,000 patient population, although there's a fair amount of variation within that. Involvement requires signing up to an add-on to the GP contract that GPs have with government to provide primary care services. And an increasing amount of funding to general practice is being funneled through this network contract. One key feature is the additional roles reimbursement scheme, whereby networks are remunerated for significant proportions of the cost of employing certain additional clinical staff to address workforce challenges. There are also a number of service specifications, such as enhanced health and care homes or personalised care, and the Investment and Impact Fund, which remunerates networks for hitting certain performance targets. Interorganisational networks are increasingly used as a mode of governance and delivery in many public sectors, particularly in the interests of tackling wicked problems. Policymakers often look to networks because of a number of perceived benefits compared with more hierarchical arrangements. These include presumed increased flexibility and adaptability, better ability to deal with complexity, better management of shared resources, and capacity to facilitate learning and innovation. Spontaneous or organic networks tend to emerge as a result of mutual interdependencies that creates incentives for collaborative action towards joint benefit and reduces incentives for members to act opportunistically. Such networks tend to exhibit high degrees of clan-based qualities such as trust, reciprocity, and shared goals. However, most of the networks that we see in public sector fields, and health and care in particular, are to some degree mandated by the policymaker or governing authority. And mandating exists on a spectrum, so organisations might be compelled to join and have much of their composition, dynamics, and operation imposed by the governing authority. Or it might be that they're just prescribed some aspect of financing arrangements, membership composition, governance processes, or the timing of certain activities, for example. But mandating networks has certain implications for the way that networks operate and the extent to which those sorts of clan-based qualities can be realised. The strength of incentives for involvement has meant that the vast majority of practices have decided to join a PCN. So while involvement is not fully mandatory, PCNs occupy somewhere close to the mandated end of the spectrum. Some of our work on the project so far has involved an analysis of the multiplicity of aims for PCNs and the fact that they serve as a vehicle for a range of expectations for different stakeholders. PCNs have been framed as a means of supporting or even rescuing general practice through resources and additional staff, also as a form through which general practice can engage in a more concerted fashion with various local providers and stakeholders in their local places and address population health and health inequalities. And they're also seen as a conduit for providing a voice for general practice at higher levels of the system, particularly in integrated care systems. So this work has emerged from our PRUCOM 3-year Mixed Methods National Evaluation of PCNs, which began in July 2020. We conducted semi-structured interviews with policymakers to inform a more nuanced understanding of the aims of the policy, as I've referred to above. So 2 rounds of a telephone survey were also conducted, so that involved interviews with local commissioners, and the second round took place in late summer and autumn 2020 and gathered their views on PCNs since the start of the pandemic. And we conducted qualitative case studies in 6 CCG areas with a diverse collection of 7 PCNs. So this presentation is primarily informed by the meeting observations and semi-structured interviews with PCN members and related local stakeholders, and the vast majority of which took place after March 2020. And this is all in service to an additional research question that we added, which focuses specifically on the role of the pandemic in shaping the collaborative working of PCNs and the implications of this period. So, in early response, several PCNs talked about issues around receiving and implementing central guidance from NHS England during the very earliest stages of the pandemic. And the frequency and amount of information became very difficult to keep on top of for PCNs that lacked some kind of higher level filter that could digest and simplify information about required actions. And in some cases, this occurred through a federation, a CCG, a manager, or some kind of coordinating entity. We heard about the anxieties of those in general practice, which were particularly acute during the early stages of the pandemic, when little was known about the virus. And clinical directors, so those in a specific leadership position of PCNs, often GPs, reported particularly pronounced stress during this time, particularly for those that were fairly new to roles of this kind. Importantly, at this time, several of the planned service specifications were delayed and a number of requirements in the GP contract suspended to allow general practice more bandwidth to address the pandemic. Procuring PPE for use in general practice was highlighted as something that lent a degree of legitimacy to PCNs locally, where they'd been successful in doing this. But as this quote highlights, there were also feelings of guilt associated with this in some cases. And in other case sites, it was a local federation that took responsibility for PPE procurement and distribution, including in one case a federation leader handing it out to members from the boot of a car. Hot hubs, whereby COVID positive patients could be seen in general practice and separated from those without COVID, were established in the vast majority of sites and in some cases involved a multiplicity of PCNs working collaboratively. This quote highlights that in one PCN, the initial response from some members, those that had sufficient estates, was to make their own arrangements for this, to the detriment of smaller member practices that did not have the facilities to do so themselves. Now, in this case, the situation was resolved after a short length of time and a more collaborative, collegial approach taken. In most cases, participants talked about this phase of the pandemic as a boost to their collaboration. So PCN members developed familiarity where this was lacking quite quickly and built closer relationships with other local providers such as community trusts in order to reorganize services at great speed. And this was made more complex at times by a lack of clarity over who was in charge of PCN activities, whether that was the local clinical commissioning group, CCG, or NHS England. In some cases, networks appealed for funding and permission to institute new pandemic response arrangements and felt that the request was unhelpfully passed back and forth between these governing organisations. The COVID-19 vaccination program was delivered in part by GP practices that had to do so collaboratively as part of a group, typically an established PCN, with some local discretion for delivery approach. It was delivered using an enhanced service contract negotiated between NHS England as the commissioner and the British Medical Association on behalf of GPs. The first vaccines were provided from early December 2020, and all of our sites gradually took part in the programme in some manner, with start dates based on vaccine supply availability. It's really important to emphasise the enormity of the shifting logistical issues that PCNs had to deal with that we witnessed in our sites, and these included developing protocols for vaccine storage, administration and eligibility, setting up vaccination centres and having them approved, some of them having to move to new vaccination centres, staffing those centres, booking systems and cohort searches, delivering vaccinations to care homes and housebound patients, and distributing funding between member practices. We saw PCNs approach this quite differently. So some worked to deliver the programme together with a lot of CCG support, whereas others went alone. The local knowledge of GP practice members was often put to good use in terms of identifying patient cohorts that might be difficult to reach and adapting the programme to try and do so. And this included pop-up clinics in community centres or religious buildings, or roving vaccine vehicles. With successive vaccination programme waves, the number of PCN members in each site willing to take part diminished. A likely contributing factor to this was that over time GPs were increasingly expected to deliver services as usual and deal with increased demand associated with those that had put off seeking care during the more acute phases of the pandemic or needed support while waiting for assessment and treatment in secondary care. And in some cases this resulted in practices taking part in name only, as the implementation work was taken on by a smaller group of committed practices and individuals. And this quote reflects the nature of this uneven distribution of labour. So what does the pandemic illuminate about PCNs? Well, the response of these networks to COVID-19 provided an enforced early opportunity to work collaboratively to deal with an existential threat. In many cases, this strengthened joint working and fostered good relationships, both within the PCN and with broader system partners, and in some cases demonstrated potential for future place-based collaborative service provision. Through this period, some PCNs demonstrated benefits of collaborative primary care at scale, whether through pooling resources to organise hot hubs and vaccine clinics, or utilising local knowledge of patient populations to have meaningful conversations to address vaccine hesitancy. It's important to stress, however, that we observed vastly different levels of pre-existing relationship strength, support and place-level coordination between our sites, which amounts to a very unequal distribution of collaborative potential. And even when focused on addressing the pandemic, and with many of the usual obligations and restrictions temporarily brushed aside, the slightly febrile nature of PCN collaborations began to tell in terms of participation in vaccine programme delivery. And as such, the limits of PCN's ability to realise collaboration beyond a rather limited set of circumstances remains somewhat untested. As something close to mandated networks, there's little to suggest that the incentives and mutual interdependencies that have been engineered through policy are sufficient to realise over 1,000 robust collaborative networks that can be built upon in future policy focused on other health system levels. A heavy reliance of goodwill of small contingents in leadership roles to keep the PCN show on the road will be difficult to sustain in the long term, but we'll have to watch to see how PCNs evolve from here. So thank you very much for listening. If you have any questions or comments, please feel free to send me an email. There's further information about PRUCOM projects and our interim report for this project specifically available in the links provided. Thank you very much.